All right, we have a great group this morning, so it is wonderful to see everybody, and we have a terrific interview. Dr. Giselle Corbie-Smith from the UNC Health System, and we're going to talk about some of the areas that she's been interested in and working. So, but first of all, let's get started. Good morning, Coalition. It's good to see you. So Allison, give us a quick update, please.
Hi, good morning, everyone, and happy Friday. I'm glad you're with us this morning. I just have two quick updates today. One, just a reminder that the coalition meeting is next Friday at 10 o'clock. So please join us for that. And then the second reminder is that the National Pulse did a meet and greet virtual session, and I will go ahead and send out the recording of that today. That lists the updates on the Pulse form that they're doing, their technology guide, and then some updated FAQs. So I'll go ahead and get that link out to you today. So watch for that member email. Thank you.
Great, thank you, Allison. So we have Dr. Giselle Corbie-Smith. I know her through the Andrea Harris task force that my wife is, this lady here is on. And so I just got to meet her, however, for the first time this morning as we did a little pre-interview discussion about her background, but she is a full professor at the UNC Health System in social medicine. She's a internal medicine doc. She's the director for the Center for Health Equity Research, chair. I'm not going to try to go into all of the things that she has done because that list is long, long, long. But first of all, I want to just say thank you for joining us, Dr. Corbie-Smith, and we appreciate you being here this morning. I will say that she is going to also talk about a podcast that she particularly has started and has been running for 3 seasons now. But before she gets into that, I want to talk about where she grew up and what she did when she was a young person. That's a typical question that I like to ask. So if you don't mind, give us a little bit of the history of Giselle Corbie-Smith, please.
Well, David, thank you so much, and happy Friday to everyone. So I grew up in Brooklyn, New York, and this is, if anybody has been to Brooklyn recently, it's a very different place. I grew up in East Flatbush, New York, and my parents are from the Caribbean. They and immigrated to the United States before I was born. So I was born in the US, but at 6 months old was already back in the Caribbean with family. And those ties to Trinidad, where my parents are from, remained pretty strong. Every summer I back there. And that sense of family and connectedness has always been an important part of who I am and the work that I do. I went to New York City public schools. The year that I graduated, the high school that I graduated from had the highest reported crime rate in New York City, which is quite a feat. Yeah. I think it was the grounding in family that really allowed me to move past that kind of environment. I went to Cornell University for undergraduate, Albert Einstein College of Medicine for medical school, and Yale for residency, and I did a chief year. I was asked to be chief resident while I was there, it's I think those very early. Sorry, I should have turned my phone off there. I think those early experiences. My mom is a nurse, and my dad worked as a New York City transit worker in the train yards, and I think that there's so much about my background that has led me to this place. One, growing up as a child of immigrants, if anybody has in the audience has that experience, you know that work ethic is strong, and that was infused in all of us. And I'm the oldest of 4 siblings. four living siblings. My parents actually came to the United States from my older sister, who passed away within days of their arrival from a cardiac anomaly. And I think it's that, again, that history, that sense of work ethic, and just watching my parents support their family members as they came over to the United States, that really, that sense of giving back, seeing them do that in so many ways, informally and formally, in their own work, in our family, in their community, that led me to really start to think about health inequality, seeing that every day in Brooklyn, in that time in Brooklyn, before it became a popular place for people sort of the upwardly mobile to move to. Seeing that, and really sort of solidified my commitment in medical school to go back to Brooklyn and to hang out a shingle, and to really support my community. And it was during residency that I knew nothing about research. I actually did a summer, I should say, in a basic science lab. And I very quickly realized that that was not the place for me. I couldn't understand why I was pipetting when there should be machines that did it. I was so inaccurate in my pipetting, and it just, while I respected the science, I knew that it was not for me. And it was during residency, and that chief year, actually, that my chair of medicine said, you have all these questions, and seeing differences in the way people were being treated based on their race and ethnicity, being treated based on their social class, being treated differently. And that was in the midst of the AIDS epidemic, because they were a sexual or gender minority. And I kept pushing back on this with both my juniors, as well as the people that were above me. And my chair said, you have a lot of questions. Have you thought about research? And the field of health disparities and health equity was just not even on the map. But I remember one grand rounds, a woman who would later become my career mentor came and presented on vulnerability in medicine, and presented her research. And it was like a light bulb went off. And I'm like, that you can do this, you can research the kinds of questions that I've had all along. That was, I think that was one of those defining moments. And that's sort of, I think, really led the path, or created a path for me to be doing health equity research, shaped where I practice clinically. I decided to have my practice in a community health center. So because the amount of research that I do, I only have a little bit of clinical time, only Friday afternoons, which I'll be doing this afternoon. I wanted to make sure that I was caring for people that wanted to be seen by someone like myself, and also that their experiences would inform the research that I did. I was very intentional about wanting to care for poor people. So I think that answers your question, David. I think I went a little bit beyond.
No.
But that's how I got to be where I am today.
Oh, that's wonderful. That's wonderful. I mean, that's the kind of thing that we like to get at here. So, and I'm sorry to hear about your older sibling, but how much did that influence what you decided to do? Because you said your mother was a nurse, but your father was a transportation worker. But you took that and went another direction, not another direction, but you amplified that and built more into that. How much did the surroundings and the circumstances of your early life influence what you're now doing?
Absolutely. As a teenager, so my mom, I was good at science and math. I loved math. I can't add any numbers right now, but I loved math at that point in time in high school and college. And she said, you really should think about medicine. And of course, as a teenager, when your mom tells you to do one thing, you end up going in the other direction.
No.
But she made sure to, as during summers, she would set up internships for me to work with folks in the hospital. So I got more exposure, in addition to other jobs that I had that actually paid me. But it was those early experiences and her sort of urging that I even considered medicine as a field. And I'm so grateful that that I did. The story of my older sister was always there. It was not something that they shielded us from. My parents, before they came to the U.S., lived in London, and really came to the U.S. to seek care for her. And sort of that being able, and my older sister was cared for the her short life at Columbia University. So yeah, I can't imagine how that would not have influences the work that I've done. I think while I'm not an OBGYN, I'm a general internist. That primary care, the access to care, Catherine and I have I have the great fortune of being able to work with Catherine on the governor's Andrea Harris Task Force on Health Equity. And we're on this access to care subcommittee, and it constantly is shaping the work that I do, and the drive to do it, frankly.
Absolutely. And thank you for, man, the idea that somebody as accomplished as you are, and just take it that way, would then say, I want to work in a clinic where I can treat poor people because I understand them. I understand where they're coming from. I understand their situation. That's significant. What drove you to say that at that point?
Well, I'll reframe what you said, David. It's I want to understand. I want that experience of my patients to constantly inform the work that I do. And I think it can, and particularly, we're in the midst of the pandemic. I have patients who have chosen not to be vaccinated. I have patients who have chosen to be vaccinated. I need to understand their motivations. I need to support them in their decision making, and I need to stand by them regardless of the decision that they've made. And I think that the pandemic is just one incredible example of why I do what I do. The inequalities that we saw early on was really no surprise to any of us that have done health equity research, have cared for poor or historically marginalized populations. Was no surprise to us. It was just, we didn't have the data for a while in terms of race and ethnicity to be able to really have full knowledge of the scope of the problem. My brother is an essential worker. My cousin is an essential worker. My brother-in-law or ex-brother-in-law, I don't know how that works when they're divorced, but is an essential worker. And 2 out of those 3 have gotten COVID in New York City. And because of the work that they've done. And so so staying close to and centering the experiences of those that are most vulnerable in our communities is really, to me, essential to being able to actually develop solutions, test solutions, and create policies that allow all of us to have an opportunity to live a healthy life.
Well, that is crucially important. So again, thank you for doing that. So all of this was done up in New York, and then at some point you decided.
Yeah. So after residency in Connecticut, I spent 5 years at Emory Grady Hospital, which was another one of those defining moments. Anybody at Grady could be anywhere else, but make that choice to care for the population at Grady Hospital, and then moved to UNC 21 years ago now, which is longer than I've lived any place, frankly. Longer than I lived in my parents' house, for sure. And which still surprises me that I actually have been here 21 years.
Well, don't leave.
Yeah. Yeah, and in the last 8 years, had the good fortune of working with colleagues to stand up the Center for Health Equity Research as a way to bring together individuals who were doing this work, and to create that sense of community, which is so important to advance this work, both methodologically and scientifically at UNC and really across the state.
What would you say is the most challenging part of that research that you've been engaged in?
Well, the work, so I would say that there are probably two or more things, and maybe more will come to mind. The first is the scope of the issue, the scope of the problem. It's everywhere all the time. And how do you start? And I'm so grateful to the colleagues that I get to work with, because they're really some of the most brilliant minds that I've had an opportunity to work with. This issue around social determinants of health, they were thinking about this, maybe not naming it in that way, but thinking about the much broader system in which our patients live, work, and play, and how that influences health long before it had a catchy name and people were, trying to figure out how to get it into the electronic health record. The other part of this work that's challenging is it's deeply personal. I think, I'm not alone in terms of why people do this work. And last year has been challenging, I think, for a lot of us. It's just there's no end to the work that needs to happen, right? And so making sure that we, shore ourselves up, making sure that we're staying connected to the people that are around us, I think is an essential part of the work that we do. And both why we love what we do and why it can be challenging.
Yeah, absolutely. Well, as I mentioned, our Serious Illness Coalition is new, but we've got 4 working groups that are focused on caregiving and patient engagement and clinical practice and advanced care planning and communications and advocacy. We're hoping to get a new bill passed on advanced care planning here. Sue Collier, who has from the beginning chaired our caregiving and patient engagement working group, asked the question, what might or how might our coalition reinforce and support the work that you're doing with underserved and minority populations? Are there some things you could imagine that we might be able to help with?
So first of all, thank you all for doing this work. It's so important. And you all probably know better than most around the inequalities when it comes to serious illness, comorbidities, and the disproportionate impact in historically marginalized populations, in racial and ethnic minorities, and rural communities that we see. Most of my work is actually in rural communities in Eastern North Carolina, most of the research that I do with my partners there. And so it's that intersection of race and geography and social class that I think you all are right at that sweet spot in thinking about serious illness and multiple comorbidities, impact on individuals, impact on families, and impact on communities. And I think what I have been sharing or suggesting to organizations is that health equity needs to be a strategic priority and clearly laid out. And and that may be the case, knowing Catherine, I wouldn't be surprised if it was the case for your work. And particularly as we age, these, aging in the setting of serious illness, in the setting of multiple comorbidities is a different, it's a different physical, a different chronological age to go with the physical aging. And I think that awareness also, all of these intersections, I think, and the appreciation of intersectionality as it relates to serious illness, I think is critically important.
So Giselle, I want to pick up on that because you said something that's really important. You said intentionality. And how can we as a serious illness coalition and as people that care about this work move it from being we need to always remember it to really being very intentional and direct about it? How does it become a priority?
I can tell you what I have done when I was president of the Society of General Internal Medicine. We did some strategic planning, and we noted it as a value and a set of principles, equity, diversity, and inclusion being sort of right up there. We had it as it was embedded in our mission statement. And for our strategic goals, it was noted as its own goal and also embedded in all the goals. So I think rather than a nice to have, it was a gotta have in any work that we did. Mhm.
That's great. So you've got several AARP folks here, either former staff, current staff. We got anyway, I won't go into all that, but we got a bunch of folks from AARP here. And so that comment that you made about aging, I mean, beyond the AARP world, we're also very interested in that. But question from Mary Bethel, who is one of our former AARP staff people and has had multiple careers. What are some of the current areas of research at UNC Health Equity Research, at the Center for Health Equity Research?
Yeah, well, we've, embraced COVID and the inequalities that exist there. We're part of, with Duke Clinical Research Institute, we're leading a consortium. We're the coordinating center that leads a consortium around testing and support for testing in underserved populations across the United States. We're also doing work on cardiovascular risk reduction. So really focusing on chronic illness as, and cardiovascular risk reduction, encompasses so many chronic illnesses and serious illnesses. And so, and we're working, all of our work is based in and centered and in collaboration with communities. So to make sure, again, that the solutions that we come up with and the solutions that we test are relevant and grounded in the concerns and interests of community members. So cardiovascular risk reduction, we have investigators that are working on health equity and sexual and gender minority populations, particularly around cancer and HIV. We have investigators that are working in American Indian populations around environmental justice. We have investigators that are working on equity in the criminal justice system and sort of looking at transitions of care and how we can support individuals who've been incarcerated, look at the disproportionality of who's incarcerated and over policing, and how people get into our carceral system and age in our carceral systems, and then what happens when they come out, and how can we support them in that transition when they've paid their debt to society. Yeah, we have a really broad swath of research that's happening there. These are just the ones that come to mind.
That's amazing. You ought to be on a governor's task force on.
Well, this is not all my work. These are my colleagues and investigators that are working, that doing this incredible work around the state and around the country.
Yeah, no, I was being facetious. So you told us about a podcast that you have. Tell us more about what a different kind of leader represents to you, particularly in that podcast.
So some of the work that I'm involved with my colleague Claudia Fernandez is around leadership development and how leadership can advance the principles of health equity. We have Clinical Scholars is a leadership development program, a National Leadership Institute funded by the Robert Wood Johnson Foundation. And we work with interprofessional teams across the country and our territories to advance health equity and have an equity-centered framework. And as we were developing this, the leaders that I saw that were doing this work were just so impressive, committed, and had experienced adversity on their own as well, that sort of burnished them, and is what I think about, burnished them in a way that really allowed them to be exceptional leaders in the space, really innovators and sort of at the vanguard and cutting edge. And I wanted to showcase that. And so A Different Kind of Leader is a podcast that focuses on diverse leaders in healthcare, public health, and academic settings or in private settings, and to really showcase their story in the same ways that you're doing, David, today and have done over the last several months, and to really to help inspire folks. So this is the podcast that I wish I had had when I was a junior person, somebody to those intimate conversations with another, the leader that I aspired to be. And so that was the genesis of the podcast. And in fact, I'd been thinking about it for a couple of years, and had been talking about it with some of the participants in our leadership development program. And one of them said, "Giselle, you've been talking about this for 2 years. When are you going to do it?" And so that's how it started. It was he threw the gauntlet down, and that's how we started recording.
That's great.
Mhm.
What was your favorite interview?
I cannot say that. How can I choose amongst my children?
I understand. I understand.
What's been the biggest surprise you've had from the interviews?
The biggest surprise, so we ask 5 questions at the end, and one of the questions is about self-care. And the biggest surprise to me is how committed each of them are to the idea of self-care. Now, many of them acknowledge that they are not as good about self-care as they need to, but they all have a practice that they are working on to keep themselves whole and healthy in their work. And it's really sort of reinforced my commitment to doing that for myself.
What do you see the future of particularly health equity research being? What are some of the areas you haven't been able to focus as much on that you imagine over the next 5 years will become really important?
Well, I'm excited about how we can create impact, how our research can be really inform policy to have a bigger impact. And so, there was a recent, I think it was just this week, a report that sort of identified the increasing diversity of our country. And so this is not a Black and brown problem, right? Health equity is not a Black and brown problem. I think there's a quote, which I'm going to misquote, that from Dr. Martin Luther King, that talks about the inextricable tapestry of mutuality, the fact that what happens to one of us happens to all of us, either directly or indirectly. So this is not just a Giselle problem because I'm brown. This is an all of us problem, and all of us need to be in this fight because we are all connected. And that's why I do the work that I do. And that's why I'm interested in equity in rural populations, as well as racial and ethnic populations, any populations that have been historically marginalized, either directly or indirectly. It impacts all of us. And all of us then need to be in the fight to ensure that we all have that opportunity to live a healthy life.
Excellent, excellent. So another question from Sue Collier, our great nurse caregiver here. She asks, what ways do you actively and intentionally engage patients and caregivers in your work and research?
Oh, thank you, Sue, for that question. As I said, my research is always centered on the perspectives of patients, families, or communities. It's to me, that's the only way that I can know that my work is relevant, that it addresses a felt need, and that it's actionable at the end. And so there's no research that we do in the center that doesn't center that perspective.
Wonderful. Any parting thoughts, because we're about 30 seconds out?
Well, I'm just grateful for this space. Thank you so much. You're such a gracious host, David. And it's been really my pleasure to work with Catherine on the task force. And I'm so grateful for the work that you all are doing around serious illness. It's so important at this moment in time.
Well, we hope you won't be a stranger to the Serious Illness Coalition. It is a virtual group. We got started right at the beginning of the pandemic, and it's been virtual ever since. And that's been, I think, one of our strengths as well as one of the challenges. But anyway, we look forward to seeing you more.
And in your travels, as you meet people that you see that have an interest in serious illness, send them our way.
Absolutely. Absolutely. Thank you. Thank you for having me today.
Thanks so much. It's great to see you.
Mm.
Y'all
Bye,
have a great
everyone.
weekend. Take care. Bye-bye.